This conference will now be recorded.
Good evening to all of our candidates who are preparing for different MRCOG examinations. Today's video is going to be quite short video, just about very basic and simple pathways and processes of our obs and gynae patients' journey through NHS. Because I have been continuously receiving different queries and questions from the candidates to know about how the transfer and continuity of care of the patients is arranged from community to hospital and even to specialized services and then back to the community. And who will do what? So that's the main question, which I can understand may be a bit tricky and difficult for people who do not work here in UK. So they want to know who will be doing what, who is going to make or arrange the referrals, who will follow the patient throughout this journey, who will be primarily responsible for that patient, and then say who is going to prescribe certain medications, and who will carry the overall different surgical procedures. Maybe they're going to be registrars or consultants. So most of you know me. I'm Dr. Safia Jabin, the main lead course organizer, MRCOG Overseas. You all might have noted the name of the top of this slide says Easy MRCOG. We have just changed our name because we really believe that passing MRCOG, all three parts, is really simple and easy. But obviously, if it has been prepared by the right technique from the very beginning. And that's what we basically do. We try to help people to make this examination very easy and understandable for them, and help them to reduce their overall process of stress throughout the course of their preparation and then even appearing in the exam. So so these are a few different type of queries which may appear very basic and very simple to most of the people who work in UK, but they can sometimes be really conflicting, rather confusing questions and point for these candidates who are preparing for the examination from overseas, because the system of examination is even different for them, and obviously most of the time they are very much anxious about saying like what they should be saying in the exam and what they should not, and then obviously they do worry about okay, who is going to do what. So these were just few quoted queries which I had to save, like many people have asked me if we have a patient for emergency copper coil insertion, who will do this insertion? Are we going to insert the coil, or we're going to only provide her information and then we are going to arrange her appointment with the sexual health? And then similarly, patients who need regular contraception or HRT, who will arrange and prescribe this HRT? Is that going to be by us, the gynecologist, or GP basically will do that HRT? So this is from exam point of view. They want to know like what we should be saying to the patient after consultation, that are we going to prescribe you this HRT, say for example, or this contraception, or are we going to give the information and they say, well, I'm going to write to your GP to prescribe or arrange for you. Similarly, termination of pregnancy process, where this happens, who actually arranged that and who does it. Sexual assault care pathway, and I think the most difficult people find is the safeguarding, both for adult and children pathways. So I have tried to put them in very simple and basic ways for you to understand what it is, just to help you make it easier. So obviously these are just very short snap of these processes and the pathways. Obviously these are not the full detailed processes, so don't take it as an exhaustive list and not as a the complete structure. Obviously if we go into explanation of the complete structure of NHS on how the services, different services do communicate with each other and integrate each other and what the process and the pathways are, that will take at least 4-hour session, which obviously cannot be arranged. This is very simple and basic point, relevant just to for the candidates for exam point of view. So to understand that, I have tried to just put some simple care process, the patient journey, and what that is. So there are 3 different levels of care these services has been divided. So the first one is called primary care. This is also called community care, and the reason for that is because these clinics or these services, they are basically located outside the hospital, acute hospitals. So they are just in the community. So first, number one of them all is general practitioners, also called GPs. Then for contraception and sexually transmitted infections, and for termination of pregnancy, there are services which are also located in the community. So they are called sexual health services. The sexual health services is a new name given to the integrated services of previously called gender unity medicine or GUM and contraception. So these both services have been integrated now, and collectively they call sexual health services. These services do have a direct access, and they are confidential and closed services. Now, what does that mean when I say direct access? Now, what happens mainly, most of the the care people need, GP is the first point of contact. So the patient get registered with the GP, and for all these basic non-urgent, non-emergency situations, they will approach the GP first. They will be seen by the GP, and if the GP feels they really need some specialist input and a long-term management plan, and they require like maybe admission in the hospital or some surgical procedures, then GP will write and refer them to appropriate specialty. But these sexual health services for contraception and sexually transmitted infections, these clients don't need to come through GP, and the reason is simple: just to make it more accessible for the people. So because obviously there can be some stigma attached to sexual health. So sometimes that can be a barrier that people don't want to go and speak to their GP. So these services are direct access by the clients. They can just ring to make an appointment. They can walk in these services, so they don't have to go through GP. Confidential and closed services. So confidential, obviously all the records of the patients are confidential, at all levels of the services. However, some of their records, like in the GP and the hospital record, they can be accessible to other services with the consent. But the sexual health services are closed services. These patients are not identifiable in these services. So we don't communicate with the GP or to the hospital. We don't write them back to the GPs unless there is something which needs long-term and lifelong management, like the patient's diagnosed with maybe HIV or with hepatitis or any other condition, and in that one, the sexual health services clinicians will take consent from the patient, and they will give only relevant information to the GP. But if the patients want not to share that information with the GP, that will be respected. So there is no necessarily a written communication between sexual health services and the GP or with the hospital. But any patient who is referred from GP to the hospital, when they are seen by the appropriate specialty, they will write back to the GP regarding their patient that there has been seen, and this is what has been done with them, which was required. Then sexual assault referral centers, they are also community-based and they're called primary care. Sexual assault referral centers are also called SARC, as you can see, SARC, and they are actually basically integrated service, which comprises of medical team, the doctors and the police. These services also have the direct access, so the victims, the clients can directly access their service without discussing with the GP. And again, this is also confidential and closed services. Termination of pregnancy services apply the same room. They are community-based clinics, and they can be directly accessed by the clients. And then comes the community midwifery. Community midwifery is, it's a shared practice. Usually these community midwives, they may have their own independent clinics. Usually they have shared practice with the GPs. So when we are talking about community midwives, so what happens when somebody, any women find themselves they are pregnant, they will actually first go to their GP and get their pregnancy booked. So some GPs will do their basic initial antenatal care themselves. And if they have any risk factors, then they will refer them again, write a letter to obstetric consultants to transfer that care to the obstetric consultants. For the low risk patients, where there is no, complex issues, then these antenatal care will be taken out in the community. So either that is by the GPs or by the midwives, and this midwifery team is working on in the community. They are integrated. They will be in connection with the hospital-based team as well. But the patients will be seen mainly in the community. They don't need to go to the acute hospitals and into the outpatient clinics to see the doctors. Then there is community mental health team. Now, community mental health team is a part of the hospital-based mental health team. So they work as a continuation of the mental health care of some patients who are being discharged from the hospital and who need long-term care and support in the community. But this one is not direct access. So for somebody if we have any patient who suffers, or any pregnant woman, or even gynae patients, or postnatal depression, their long-term care in the community will be seen by community mental health team. But they will need a referral from us. So it will be either from the specialist, it can be from GP, and it can be from the mental health team in the hospital, based in the hospital. And the community health team is, again, they also do have one acute outreach teams. Acute outreach teams are when the patients or somebody have actually acute mental health crisis in the community. Somebody's, have a really in the acute condition, and they're thinking of suicide or any attempt are out of hours of the hospital, then this acute outreach team can actually go and see them, and they can liaise with the consultant psychiatrist later on and get the advice. Physiotherapy access is through GP, our specialty referrals. As in our favorite, we like to send all of our prolapse patients and incontinence, stress incontinence patients for pelvic floor exercises. Now that's also this physiotherapy can be based in the community. It can be they can be located into the acute trusts as well. But they are not direct access. Again, they are referred through the GPs or from these specialties. So these are the patients where the patients who have the sexual health service needs or contraception needs, termination, and sexual assault, they can be completely seen and managed into the community without even involving the GP. They will have a complete health plan by these services. The rest obviously needs to be a link between these services. So for any patient transferred from the general practitioner to the hospital, then GP and hospital need to communicate with each other. They need to talk to each other. So GP would be writing a letter to the services to say, I'm sending this patient with this blah blah, and then once their treatment and management plan has been taken, then you discharge the patient from the hospital, and there comes the discharge letter importance. So you will be then writing back the discharge letter to the GP to say, your patient came with this, and we have done these investigations, these management plan, this was the diagnosis, these complications happen. Say for example, if it any happen, the surgery has taken place, and now we are discharging the patient is stable, and this is the condition. And then you also will write down then if there are any test results which are awaited, you will ask the GP to chase them up, or you will be asking to continue with this care in the community. And the reason for transfer or trying to manage more and more patients in the community is to try to reduce the workload on acute services, because these acute hospitals, obviously, they can be very busy. And if we don't dedicate these services in the community as many as we can, then obviously the care of the hospital acute patients care can be compromised. So next level of care is called secondary care, and they are the local hospitals. So we will just stay to our specialty. So in gynae, this care is comprised of gynae outpatient clinics based in the hospital, postmenopausal bleeding clinics. They are fast-track referrals, and that can be, these referrals can be by GP, gynae clinics, even from sexual health clinic. So these are the like any patients who come to the GP or sexual health clinics or even to the gynae clinic, outpatient clinics, and they have a history of postmenopausal bleeding. You will do the fast track to these specialized clinics. And they're also got one-stop shop where the patients will have transvaginal scan done first, and following that, in the same appointment, within the process of a couple of hours, they will be seen by the gynecologist after that, who will then decide to do the outpatient flexible hysteroscopy, depending on the findings and the history of the patient. Findings of the transvaginal scan and also the history of the patient, they will decide to do flexible outpatient hysteroscopy and then also take endometrial biopsy. Then are the colposcopy clinics. Obviously, we know they deal with abnormal smears and with any cervical biopsies. And these clinics receive the patient. They get direct referral from National Cervical Screening Services. So when we send the smears to the laboratory, those results go to National Cervical Screening Services as well, and we get the results back as well. So anybody whose results are abnormal and they need colposcopy referral, they are actually directly referred by the National Cervical Screening Services straight to the colposcopy clinics to avoid any further delay in the transfer of these patients, because they usually are fast-track referral as well. But obviously, the practitioners who have taken the smear in the first place, they are also sent the result. And then we also then just contact the patient to make sure that they have received that appointment from the colposcopy clinic, and we sometimes invite them to give them some information before they can go and see the colposcopy clinic, just to make sure that they do attend. Sometimes you need to give them that information to try to understand the importance of their appointment. Then comes the gynae assessment unit. Gynae assessment units are like to deal with the with some urgent or acute conditions. So this unit, basically the patients who have some problems, they attend acute pains, pelvic pains, or any other gynecological problems, and they are basically triage units. So they will be assessed over there initially, and then depending upon whether they can be given some treatment and then sent home, they can be sent home, or if they need any admissions, then they will be admitted to the ward, or maybe we have given some treatment now, arrange their scan or some test, and then we can bring them back for the follow-up in outpatient gynae clinics. And then obviously finally is the the gynae wards for those patients with needs inpatient. How the obstetrics work. So we have initially talked about the primary care. In the primary care, what happens? Any pregnant woman will first get booked with the GP, and then the ones which are simple pregnancies without any risk factors, their care will continue in the community. They don't need to see the doctors and consultant-led care. However, the complex pregnancies, pregnancies with any risk factors, they will be then referred to antenatal outpatient clinics, which is also called consultant-led care. So they are patients with their antenatal care will be continued in these clinics. Then you have early pregnancy assessment units as well. Early pregnancy assessment unit basically come under gynae care, because that's the acute pregnancy problems before 12 weeks. But anyway, this is pregnancy related, so I have put it under obstetrics. So how the patients can actually get to early pregnancy assessment unit, they are usually the referrals either from A&E. The patients have, say, acute abdominal pain or any bleeding, so they usually present to A&E, and from there they will be then taken up into early pregnancy assessment unit, and their initial assessment will be done, and then accordingly they will be triaged. Or even community midwives, sometimes the patients can contact their community midwife or GP, and they can send them to early pregnancy assessment unit. And once they are seen on early pregnancy assessment unit, and if they have a problem which can be continued or whatever, they are then given direct access number for early pregnancy assessment unit. So after that, if they have that recurrence of the problem or they need any further follow-ups in that condition, then they can directly contact the early pregnancy assessment unit for advice and can also attend. Then we have maternity triage unit. Maternity triage units are parallel to kind of gynae assessment unit, as I said here. So the maternity triage unit is also direct access for all booked pregnancies. So irrespective whether they are initially booked for the community care, midwifery-led care, or obstetric consultants, consultant-led care, during pregnancy, if they have any acute problems, like they start having any abdominal pain, they have concerns about the reduced fetal movement, they develop severe headache, or any of these type of conditions, problems, they can actually come to maternity triage unit. So this is basically the acute pregnancy-related problem from 12 weeks of gestation onwards. So what happens in pregnancy, maternity triage is obviously they are kind of admitted, their initial assessment is taken up, the baby monitoring is done, and then depending upon what problem they have and what type of continuity of care they need, the ones which fail, they can be sent back home. They will be sent home with the advice, and if they need to be admitted for some long-term, follow-up and monitoring, or they need any further investigations, they can be then admitted on antenatal ward. Or if they have really an acute condition, then they can be even transferred to liver ward for more close monitoring. Then you have a maternity daycare unit. Obviously, they can have different names, these units in different hospitals, but they work like as it's not, this is to save again the admissions into the ward. So these are the patients who need planned continuity of care. At the monitoring side, our patients with the, PIH, gestational diabetes, who need any monitoring, need serial scans, induction of labor booking. So all these obstetric early-stasis patients, they need to have the repeat, blood tests, and so they can be. So the maternity daycare is where planned monitoring patients will be coming for their care to be taken out. So they will be seen there. There will be, dedicated midwives over there, and then they can, the midwives can obviously show these results immediately to on-call doctors, and then they can be seen, and after certain hours they can be sent home. Obviously, if they need admission, then they will be admitted in transfer to antenatal ward or labor ward. Inpatients obviously is antenatal ward, acute inpatient is labor ward, and then we all are aware of our postnatal wards. Then comes tertiary care. So tertiary care are usually called regional centers of excellence, and they are usually, we call them as they are specialized areas in usually large hospitals. So they will have outpatient gynae clinics, just the same as we have our local hospitals. So they will see their local routine patients, which obviously come under their own catchment area. And in addition to that, they will be seeing complex regional referrals as well. So in different cases, and when you guys study about different conditions, fetal-maternal conditions and all that stuff, where you say, I will arrange your appointment to see our fetal-maternal medicine consultants or specialists, then these are the centers you're talking about. So these referrals will be from the local hospital. So where the local hospital team feels we don't have those particular specialty or specialist skills available in our team, or maybe we do not have those facilities available in that hospital, they will be referred to these tertiary care centers. I mean, they just are, bigger, larger hospitals. So they will have, similarly, just like gynae, they will have their outpatient antenatal, which will have their own routine, simple plus complex patients, as well as complex regional referrals. So some of these, like specialist services like genetics, specialized assisted reproductive services, complex fetal-maternal admission for antenatal care, or even for the birth and postnatal care, say where the mother or the baby have congenital heart disease, they may have more complex requirements and more aggressive monitoring and more specially skilled monitoring during the pregnancy as well as during the labor, and then immediately after the birth the baby may need to have more specialized and high level of care. So they all will be transferred over there. And sometimes, if the baby have some heart defects, or even we say a monoclonic monoamniotic twins with twin-to-twin syndrome and other who may need some procedures immediately after the birth, or some surgery, some for heart or anything, they all will be booked with these centers right from the beginning. Whenever we diagnose these issues and problems, so that they know and they have a continuity of care right from the beginning with their particular specialist in these, rather than for us to then refer them or transfer them at the last moment near the labor. So this is how is the basic structure of the journey of a patient from community to these services. Now, obviously, once they are seen, the loop completes itself. So once these patients are seen in the local hospital, secondary care, and the tertiary care, then obviously from the tertiary care, they usually are discharged back to the care to the local hospital consultants, and they will continue with the care, and then obviously they will be and they will discharge back to the community. And this all communication usually happens through the written letters, through the telephonic communication as well. So just I will give one small example from usually routine examination scenarios, like when they say you have a preterm birth, there is a preterm twin delivery, or preterm pregnancy with ruptured membranes, and she has gone into labor at 29 weeks or something, and there is no cot available, and you need to make a referral. So that's another type of referral. This referral required because simply we do not have the cots. That's not because the baby needs some particular which we don't have. So if we are full, sometimes we have to make these referrals to our neighboring units. So but the communication is very important when we transfer this care from one service to the other, or from one colleague to the other colleague. So which means you will make a telephone call, and very clearly you will inform and you will give the full details of the patient, how the patient presented to you, what you have done, and what are your findings of examination, how stabilized the patient is, how the things are, the baby monitoring, maybe if you needed to do that, and then you will thank them to accept your patients, and then you will also send this all information in written letter to them as well. Right, so here I'm going to take a little chance and time to explain a bit about our live circuit courses. And the reason why I have added up here is because we recently advertised our two courses, live circuit courses, one in Dubai and one in Islamabad, Pakistan. But since then, we have done some changes, because initially, just for the people to book the date in their diaries, we have advertised one flyer with the dates and then estimated cost. Since then, in the last 2 weeks, we have completed now the homework of to see exactly what the cost, how much cost they will cost us in both countries. So we have basically reduced our stripes. That's a good news. We have reduced the price of both courses, which I will tell you and show you those flyers soon. And we have increased the number of circuits as well. So so this is our very first proper circuit course in Pakistan as well. And the reason why I'm saying that is we basically started this coaching and helping people first time in 2018. And that was, I was trained in Holy Family Hospital, Rawalpindi in Pakistan, and my respected professor, Dr. Rizwana Chaudhry, can be seen in this picture. She requested me to basically come and facilitate and help the girls in Pakistan, to help them to understand again these basic system, how does that work, and the very basic things for the examination and communication they need. So the very first training or coaching course, it can be said, or whatever, the first one was done in September 2018. And that was not really, again, a commercial or that type of course. The fee we had from the people was only 8,000 Pakistani rupees, which probably I think was hardly 50 pounds, because the aim was just to have this. So we have that course like about equivalent to 3 days. And we have these lovely participants who travel to our course from all over the country, like from Karachi, and some even came from Lahore and Multan. So that was organized to give them lectures, help them to understand, help them to improve their communication. And we have a very good response. Most of them who actually could manage to book that course, more than 90% of those candidates were able to pass the exam. And some of them were appearing only very first time, and they have passed that exam. So I've just put a couple of feedbacks from those candidates. So one of them was a MRCOG. So I mean, it was really surprising for me, you know, the way the girls gave me the feedback that, you know, our brains have opened up now, our eyes have opened up. Now we clearly understand what happens, what is expected in the exam from us. So yeah, so there was very lovely comments from MRCOG to say, first day of the course, and my mind has just opened up. Which was clogged already, and you know, I'm trying to unlearn things which I have learned before, and you know, his course is very good. Then we had one of our other lovely candidates, Saima Ali. She gave us this feedback afterwards to say the Saima had actually appeared in one exam before, and she had attended, she said, multiple courses, online courses, and even some circuit courses in UK, but unfortunately she couldn't clear it first time. She could score only 59%, but after doing the circuit course with us, and it's not only the circuit course I do, I continue to give them continuous support till their exam by online sessions as well, as a part of continued support. So so in the next attempt, after having the training with us, she not only passed, she passed it with really good percentage. And that's another success we have under our batches, that our candidates not only pass, they pass with very high percentage, most of them in high 70s or in 80s. We had one of these lovely girls, Shahira Osman. She was appearing first time, and actually she has started preparing after our circuit course. So she attended our circuit course, and then she said, well, you know, now I understand what it is, and if you know, continue to coach me till my exam, I'm going to give it full of my energy. So she actually prepared only for 2.5 months, and she managed to pass it in the very first attempt. This is Saika, is our last exam candidate. She appeared first time as well, and she has passed. And these course we are doing in Islamabad, Saika kindly has actually agreed to come down to help the girls there. She might actually play as a role player with us, our examiner. You know, we have taken some examiners who have recently done MRCOG. They will be trained according to the NHS, according to RCG standards beforehand. But I think that will be quite helpful as well, as these girls who have just recently passed the exam, they very clearly understand what type of, you know, queries you guys have in your mind, and how to help. So they will be available there to talk and to get help, ongoing help to your exams as well. So this was the last September one. So the fee for this course we took was I think about 25,000 Pakistani rupees, which were about, I think, 130 pounds or something. It's a 2-day course, which in this one we gave them circuits as well. I mean, there are a few girls from that course, and some of them passed in the very first attempt. So one of them was this Maria Akuma. She has passed her part 2 just in July. She just attended our course and she passed. And many of you can recognize Renu here as well. She, mashallah, has started her own coaching groups now. So very proud of these. Okay, so this is our course in Dubai. So what has been changed? So the people who have seen this flyer before, it was 2-day course. It remains 2-day course. We have reduced our candidate places from 20 to 16. because we thought with 20 people to try to give them 3 circuits, because there was a strong demand and request from people to give them at least 3 circuits to practice. So we have reduced the number of people to 16, so so that we can give them actually more individualized coaching as well. So the pattern of the course is going to be, there will be full 3 circuits. And then we will give them one online model circuit from the challenging cases of these circuits, which is recorded. These will be video recordings by myself with the role players, with the professional proper role players who are, who play in the exam, so that people can understand exactly what body language, what should be the tone, and what phrases and words we do use. Then obviously we will continue to guide you to help you how the answers should be given in perfect way to meet RCT standards and to pass. We will provide you pre-course material, will become accessible 3 weeks before the live course. So once you will book, we will be sending you all those the instructions, handouts, performance about the how different modules should be dealt with in exam, and also what are very particular safety points in each module which should be taken into account or must be considered when you are doing that counseling or having that station in the examination. And even more importantly, what you should not say in any particular module, and how you can basically express the empathy to your patients as well. We had our initially we announced the fee of that course £900, but since then we have been able to make our arrangements, complete our arrangements over there, and we realized that we actually could provide this course in £800 as well, because our aim is mainly to try to facilitate and make these courses and this coaching accessible to more and more people and make it affordable for them as well. So I think this fee is the lowest fee of all the other courses, of similar courses, which are provided for MRCOG Part 3 in Dubai for May 2020. Similarly, we have reduced the fee in our Islamabad circuit as well, and we have increased that time actually from 2 days to 3 days. So this course will be now starting from Friday, the 10th of April, till 12th of April. So there will be 3 days. Places are only strictly for 20 people. And same reason here as well. We want to focus on individually on everybody's. So there will be 3 circuits and 1 model circuit, again by myself with the role players, by UK role players. Pre-course material will be accessible to those people. So it's not only the pre-course material, there will be a lot of guidance and coaching actually beforehand, so that you are actually well prepared beforehand according to the exam standards to practice those skills in those circuits. And then further on, you will have, we will continue your post-course support as well, which will be in the form of weekly online session till the exam. This will be available to Dubai candidates as well. So you will have, so there will be like 4 weeks will be left for the exam till then. So there will be 4 live sessions, 1 weekly, each lasting for 4 hours. Where we can discuss the stations and even other exam, the FEMIS are more common and important structures. The course is, so this time, obviously we have arranged proper trained role players and the examiners, and all the role players and the examiners in both courses, Islamabad and Dubai, they are all MRCOG or FRCOG senior clinicians. And there's a mix basically. Some of them are senior, working at the assistant associate professors levels, and some are those people who have recently passed exams in last couple of years, because we thought this mix is really important, as the fresh people, past candidates basically can also provide a lot of help and knowledge and different, help to these participants in the course. So after our assessment of the cost and everything, we have found we can actually provide this course in £300. So we have reduced it from £400 to this. We just want to, again, this is absolutely non-profit. It's rather, very strict price to provide this quality of the course, really. But obviously, I feel particularly in Pakistan when I do the courses, I owe to return back to that community and that country where I got trained. And I got so much skill today that I'm in a position to help many other people now. So that's a good news. So this course has been, the changes from the previous flyer we sent out. This course is now 3-day course. There will be 3 circuits and 1 model circuit, and the price has been reduced to £300. So it will start on 10th of April till 12th of April. Then how could we forget Karachi? I have been receiving many requests from the candidates from Karachi for last 2 years, but I was not able to go there. But this time now we have tried to, we have planned this course for them as well. So hello Karachi, we are coming to your doorstep as well to help you. Although previously the people have traveled to our course from Karachi. I appreciate that. So the similar course, but that will be a 1 week before Islamabad circuit. So the Karachi, we will be in Karachi from 3rd of April to 5th of April. Places will be strictly 20, and the rest of the details of the course are same: 3 circuit, pre-course and post-course online sessions. So there will be weekly online session of 4 hours. That's, I think, the most important thing, to actually go over, discuss your individual performance even more detail, and help you to resolve other parallel scenarios as well. So during the exam as well, as I said, like we have proper, MRCG and FRCG qualified examiners and the role players. So there will be very standard RCG course, equivalent course. So after every station, there will be 3 to 4 minutes. Individualized feedback will be given to you at your station after every station. And after that, we will be giving you how the most challenging stations should be performed, and then the 4 online sessions will also continue the coaching till your exam. Right, so coming back to then in more detail, as we started to understand the process, who will do what. So there were some very specific queries I received. So I'm usually asked if we have to, so this is again examination perspective. The girls say when we are explaining the role player or in the exam to the patient that, about somebody needs IUD for emergency, who will do this insertion? Are we supposed to give the information to the patient and then say, I'm going to send you to the sexual health, or actually I'm supposed to insert the coil? Similarly, there are queries people struggle to understand: regular contraception and HRT scenarios. Are we supposed to give the information and then say the GP will start, or are we supposed to know the names and prescription? Like, are we supposed to prescribe that? And same apply to termination of pregnancy and sexual assault. Now, if you look backwards, for all the community services related to our gynae and obstetric, can be GP to start with initially, sexual health services, termination of pregnancy services, so and even sexual assault referral services. These services and the GP, if they find anything complex, we are the specialist, specialty for them. So they will be sending those patients to us. So that means the gynecologists do have an actually ultimate responsibility for all these patients. If they are not, they cannot be managed in the community. So for the exam purposes, basically, you are supposed to complete the management plan for these patients. So let's see in a little bit more detail. So for what happens routinely, so this is for you to understand the system. So what happens routinely when somebody needs IUD for emergency contraception. So in real world, how the system here works, all the emergency contraception, normal regular contraception, this will be dealt in community. So these patients won't be basically coming to gynae outpatient clinic to get some emergency contraception or even regular contraception. They will be dealt in community, and who will be doing them? GP or sexual health services, right? They will be dealing with them. But in examination, because as I said, like if these two for any reason cannot, or if there is any complex cases, they will be sending them to you, to the gynecologist, because you are their specialty. So that means, for examination point of view, in the examination, you are basically supposed to complete all that. So you're supposed to explain, take the whatever information you need together, then advise them about the process, the insertion process, removal process, the risks of the procedure, everything. And then you will complete by saying that if you're ready to go ahead, after this information, I will examine you and insert the emergency IUD for you. So you will say you are going to do, you're not going to say, I have explained you this all now, and now I send you to sexual health. No, you will basically complete that and insert that. You will say, insert it. And then mostly people say, does everybody who needs emergency coil needs a full STI screen? Yes, full STI screen will be offered to all the women prior to insertion. And the reason for that is because these STIs can sometimes be present asymptomatically in the body. And when we are doing the insertion, obviously there can be ascending infection. So we do offer this when it is, the safety point from examination point of view. You are supposed to offer STI screen to all these women. And you'll check with them, that we do offer this to all these women. So what you feel about it? Are you happy for us to take these swabs for chlamydia and gonorrhea before the insertion? However, if you find somebody have the risk factors present, like unusual discharge, multiple partners in last 3 months, or they have a new partner in last 3 months' time, or their age is less than 25, like young people, then you will offer them prophylactic antibiotics for chlamydia. So you will take the swabs anyway, but obviously swabs results are going to take time. They will come back after few days. But you are supposed to, obviously, you're going to insert the coil straight away after taking the swab. So just to be on the safer side, we will be giving them prophylactic antibiotics, at least for chlamydia. And obviously that antibiotic for chlamydia prophylaxis or treatments is doxycycline, 100 milligram, and you give it twice daily for 7 days. Regular contraception and HRT, who provides that? Gynecologist or GP. So again, in routine, simple contraception and HRT will be provided in the community. So they won't be coming to gynae outpatient. So either GP or sexual health services will provide them. But if there are any complex needs, like complex medical problems or any issues, then the sexual health services, they are consultant-led services. So if they are complex contraception, that there will be, usually these patients are seen by the consultant in the sexual health services, are senior doctors in these services, and they will prescribe or sort it out, or they can send them to gynae outpatient clinic. So in real world, you basically will be involved in regular contraception and HRT only for the complex patients. But in the examination point of view, if you have these scenarios related to do, you are supposed to complete the discussion counseling information to the patient, and then also to say, so I'm going to prescribe you whatever the method or HRT they decide to go on. Termination of pregnancy, so that is something as well people want to know. The gynae people do that, sexual health, or who will does it, and then even medical studies. So the termination of pregnancy is not done by routinely not done by the gynecologist, neither by the sexual health clinics. There are separate dedicated community-based services for termination of pregnancy. And they are direct access. These clients can directly access them, but obviously they can be signposted by the GP, sexual health community, and these services are also closed services that they are confidential. So the patients can access them either directly themselves. They can walk in, they can make an appointment, or they can be signposted. So then what happens in these services? Medical termination is completely dealt by these termination of pregnancy clinics in the community. So they will give them, oral dose, send them home, bring them back after 48 hours, and then follow and complete that, the process of medical termination. For surgical treatments, termination of pregnancy, the primary responsibility to make arrangement will be by these community GOP services at the clinics, but the patients who will opt for, well, it shouldn't call patients, they should be called clients. The clients who will opt for surgical termination of pregnancy are the clients or the patients who will need surgical or further evacuation after failed or retained products from medical treatment. Those arrangements will be made by the termination of pregnancy clinics, but they are dealt in the hospital. Yeah, so your local or acute hospital as the day goes. But that again is not like general gynae list or anything. No, that they will be dedicated named gynecologist. So even if they need to send them for the consultation before or anything, then they will contact and make the appointment or arrange their that procedure with that particular named gynecologist. And that termination will be done then as a day case, and they will be sent home. So what is the pathway for sexual assault care? So sexual assault care, the services who deal with them, they are called sexual assault referral centers. We also call them SARC. And SARC is an integrated service named police team and the medical legal team. And they are, direct access clients. The victims of sexual assault can directly, walk in, or they can ring them and go to these services. And obviously they are confidential and closed services as well. And when I say closed services, that means that once the clients are seen there, you do not necessarily have to write down to the GP for the continuity of care or anything, unless you have taken the consent. But most of the time, the patients are, the victims, they do not want their GPs to be involved immediately, at least. Later on, they may decide to disclose that information to their GPs. So we are not automatically supposed to write back to their GPs. Okay, so the medical team, what do they do basically over there? They will do any medical examination. They will collect the DNA samples and they will provide them emergency contraception. And in some centers, if they have, the more specialized doctors, then they can start HIV prophylaxis as well. After discussion with the patient, with the victim, and if she wants to, start, they may start on PrEP. Otherwise, that is usually done by the sexual health services. So in SARC, the medical examination will be completed, DNA samples will be taken, and they will usually start emergency contraception if needed. For further management, they will, make arrangements for that victim to be seen in sexual health services. In sexual health services, again, depending upon if emergency contraception has been provided them already, that's fine. But if it's not provided in SARC, then it will be provided in the sexual health services. And the other task with sexual health services they will do the sexually transmitted infection screen. They will take the swabs for chlamydia, gonorrhea, and these swabs will also depend. The site will be decided as well, depending upon what the sites of penetration. They will also do the blood tests for HIV, syphilis, and hepatitis B and C strain. The next action they need to take is to discuss and provide post-exposure prophylaxis for HIV, chlamydia, and also offer them hepatitis B vaccination, accelerated course, which will be preventive as well. So that will be done, post-exposure prophylaxis for HIV will be done after the risk assessment. And there is a criteria to do the risk assessment according to the risk factor exposures. And then we do that to see whether the post-exposure prophylaxis for HIV is recommended or not. But even if we find out that it is strongly recommended, we will advise the patient to say, well, due to these risk factors, we will advise you, or it will be a good idea to take the post-exposure prophylaxis for HIV. So how you feel about it? So it's up to the client if she wants to. We can't impose by saying that we are giving you or we need to give you. We'll say we will recommend, but we'll say how you feel, what would you like us to do? Okay, so then obviously, usually this visit is immediately after the incidence. So that means the patients, they still can be in the incubation period. So we need to then, the sexual health services need to then arrange their follow-up to cover the incubation periods according to these tests when they need to come back. And also, if they have started on PEP for HIV, that needs a review as well, usually after 2 weeks, because the PEP medication do have some toxicity. So they needs to be monitored by certain blood tests and also from different other aspects. Okay, so now regarding the third important question in this matter is they usually ask like, so what about the police? So most of the time, the clients, before they go to sexual health services, they have actually assessed SARC to the police as well. So they make a call to the police. They have informed this incident, they have been the victim of this incident, and then either police take them to SARC, to these services for these examinations of DNA, or they can directly go to that clinic and they encourage them to involve the police and inform the police. However, if the client is not quite ready at that stage and not decisive what they want to do, it's okay. All in both services can be done. These both services can take that opportunity to ask, would you like to inform the police? And if she says yes, then obviously encourage them, and then it's client's responsibility. The client herself will contact the police, and it's not the services duty. Sometimes they say no, we don't want to, but then still in SARC, they will offer them to have their DNA samples taken, even if they don't want to involve the police at this stage, so that they can have that evidence in future in case after weeks or months or years they want to actually pursue the person. So then at least they will have those evidence to be used in the court. So that was sexual assault. Now, what happens? So safeguarding pathway is really confusing, and I think the candidates find the most difficult, but it actually is very simple. So I'm just going to briefly tell you on the basic process. So again, it's not very complete and the comprehensive slides. They are just the very basic, the skeleton of the pathway. So safeguarding children and the adults both, what immediately needs to be done and what can be done after long term. So what is immediate safeguarding pathways? Now for the children under the age of 12 years, if you have any concern and if the scenario in the exam given shows any concern or with the history taking where you feel the child may have been the victim of sexual, abuse, or sexual assault, or sexual exploitation, even, and even if the, sometime the child might be, child might just say, I had that sexual activity with my consent. Even then, that will be classified as a rape. So the sexual activity under the age of 12, even with the mutual consent, will be classified as a rape, and that's a serious crime, and that is reportable, and that's your legal responsibility to report. Okay. So first of all, what you need to do, obviously, if there are any other medical and acute and other needs, you will address them. And then from safeguarding point of view, you will need to inform and discuss your concerns with your consultant. Then you will need to also involve and discuss that case with the pediatric consultant as well, because the gynecologists are not supposed to examine the child under the age of 12 particularly. So that examination will be taken over by the pediatric doctors, and that's by the consultant too. And if they need any gender examination or any screen samples, vaginal or any sample, they all will be taken, anal or vaginal, they will be taken by the pediatric consultant, and they will also decide about the admission. If you have obviously the concerns about, like, there is some sexual abuse, exploitation going on, and there is a serious risk, sometimes you need to retain the child into the services, and you will not allow them to go home, taken to the home, because you might just then lose a follow-up. And from safety point of view as well, if we have serious concerns, we have to keep that child in, even if the child doesn't need the admission from their medical needs, and that's why you need to involve them all. So still you will retain the child there till all the appropriate steps are taken. So after these two clinical people, you will then also contact immediately your Trust Children Safeguarding lead, and there are dedicated team for that. They are available 24/7. So you will give them a ring and discuss the case with them as well. So they are there actually to help you and guide you as well through the process. You know what should be done, and then you will call the police, and you will call the police. Yeah. So because there's something the people usually ask me, who will call the police. So if, again, immediate safeguarding pathway continue, but for the children from 13 to 17 year, you will inform and discuss with your consultant regarding your concerns you have. And then you will involve the gynae adolescent consultant as well, for the same reasons, for genital examination, samples, or STI. Even the gynecologist can take these for these as well under this age range. And then, you know, admission plus minus requiring, you know, depending upon the requirement. Then you will, in this case as well, you will then contact the Trust Children Safeguarding lead, and you will discuss your concerns and everything to them. But before you talk to them, actually, you will try to seek the consent from the young person. By telling them that I do have these concerns about your safety, so I would like to discuss and share these concerns with these relevant colleagues to, you know, to get some plan in place for you, because I'm concerned about your safety. Now, if that young person gives the consent, then it's fine. Even if he doesn't give, then it's important that you do inform the young person to say, you know, I'm afraid I have to, you know, continue with this process because I do have serious concerns regarding your health and safety. And also, if I don't proceed, then there can be serious risk of harm to yourself and also wider risk of harm to other children and to the community. And if it's a really serious, like, you know, rape or serious concerned about the child abuse or exploitation, say somebody have raped them or somebody is actually abusing, and, you know, and it's like not with their consent and all that stuff, then in these cases as well, sometimes you have to call the police without even the consent of the child. But before you actually call police, even both cases, you're supposed to discuss with them. So the safeguarding teams usually they're very helpful, and obviously they are there for that purpose. That's their specialty. So they are quite helpful you to, you know, give the full advice what you're supposed to do. So after that, so those were the immediate steps you need to take. So after that, what you need to do, so this is just regarding the safeguarding, right? I'm not touching the other sexual health or other medical needs. It's just the safeguarding pathway. So after you have discussed the trust safeguarding team, now what you need to do is you need to, because you do have some serious risk, you need to refer this information, in this case, to MRCOG. MRCOG is multi-agency risk assessment conference, and they are in every region, and they're very important really to basically prevent these cases from happening in the community. So MRCOG is a victim-focused information sharing and risk management meeting. So this is a conference where the key agencies do attend these conferences on a regular basis. They are usually weekly, or, you know, are at least fortnightly, where all the high-risk cases are discussed. So no, in MRCOG, it's not only the child sexual exploitation and abuse, it's domestic abuse, all sort of abuse will be discussed there. Different cases can be discussed over there. So in this conference, what is the importance of this actually meeting and discussion and this conference for all these agencies to discuss and share that information? Obviously, that process gives you that information that these different stakeholders are attending these meetings, they are present in that meeting, they're nominated person from each service coming and sitting in that. So there may be that the one agency or one service have a, you know, piece of information, and some others have some other piece of information, and some other have some piece of information, and individually with that one piece of information they might think, well, yeah, there is some concern, but it's not really significant or serious. But actually when you bring together all those three pieces of jigsaw collectively, when you see your concern, my concern, and the third person's concern, you might actually realize then by sharing all that information, that no, actually there is a lot going on here. So there are serious safety risks for this child, or domestic abuse cases. So that's one benefit of these agencies. Sorry, this MRCOG. So yeah, so they then obviously this conference enables the appropriate actions to be taken to increase the public safety, or to ensure the safety and the plan of care for that particular child or the women in domestic abuse cases. They also determine whether the perpetrator can be a significant risk to any particular individual or to the general community. So because police is a part of this as well, so they will do all that investigation, and then if they need to arrest that person or they need to separate that child from their family, they all collectively, a plan can be discussed and put into place. So they combine up-to-date risk information with a timely assessment of victims' need. So I said this MRCOG, or this conference, is attended by all key agencies. So who are those key agencies who actually attend these, and who are the part of these? Yeah, who attends the MRCOG? And these are the permanent members of MRCOG. So there is a nominated police officer for that particular purpose. So this officer is to report on cases, and other public prosecution officers as necessary. And also, obviously, the police will then investigate the case. So for example, if we come back to our examination scenarios, you have seen some child where you suspect sexual abuse. And when you said you will call the police and all that, but then obviously who is going to do the investigation when we say that whoever is doing the child is not safe, and are there other children at home? So these are information we are taking, and the police then will take all that investigation, and the children's social care as well will go visit that family and the home to see what else is going on, what is the environment at home, what can be done. Is the child safe to be left with the family, or they need to be, or the person, if the perpetrator is the part of the family, that needs to be removed or arrested. Yeah, if there is a negligence in behavior for both parents, sometimes the child will be taken away from the family and given into adoption or to some other care. So named police officer attend that meeting. Children's social care named again designated people. Some officers will be attending their service. And social care involvement is very important. Obviously, they are the ones who are going to then take the long-term support for that individual in their future needs. Specialist domestic violence services, including local women's aid or other refuge providers, and specialist projects supporting minority communities and groups. So these are all those people who can be, they kind of, you can say, vulnerable groups. So their representatives are part of there as well. So in case, if there is any case, domestic abuse, we have referred, that can be discussed over there. Health representatives, and health representative will depend, like, whoever have raised the issues and made that reference. So midwifery, health visitors, child protection nurse, hospital staff is appropriate. So whoever has referred that case, obviously that person needs to be attending that conference as well, then to to share and give the information, and also to see what actually is the plan going to be made. Because if I make some referral, I have serious concern about this woman going through the domestic abuse, and also because of that her children are at risk of abuse as well, then obviously I can't just send that referral and then just say, oh, that's fine, I'm done it. Obviously, it's just, I would like to know what action has been taken, what has happened, is that person safe now, what has been done. Yeah, so you're invited in that meeting as well. Then people from housing. So when you are talking about domestic abuse, if they have to leave from there, or from people in asylum and all that, they need to be. So all these groups are again obviously vulnerable groups. So sometimes you need to sort out their housing as well. People from education are there as well. All the schools and colleges, they do have their own safeguarding teams in their individual there as well. So whenever obviously you have the suspicion of any child abuse or exploitation, you do talk to the school nurses as well to get some information from them. Have they noticed any change in behavior? Do they know, or do they have any concerns about the safety of the child? So it's a kind of, again, trying to meet up all the pieces of the jigsaw. Representative from mental health team are there as well, homelessness team, and the representative from local drug and alcohol services are present in there as well. And Now you can say it's such a comprehensive representation is there that they all together can basically investigate the process, provide the support, provide the care plan in place. You know, they can sort out everything, and long-term ongoing care plan can be made then and there between this team. Yeah. Right. Now, this one question now, particular question, and it's interesting. I've seen this coming through many times. I have answered it many times. So I thought I put that into this as well. For some reason, I don't know, it seems to be quite a lot of confusion, and some candidates then keep sending me back by saying, you know, that some other courts or some other mentors and people have actually told them differently. So I thought I'd put the FSRH guidelines in perspective as well, to once for all, to try to make it clear for you guys. So the question is, can we offer or insert copper IUCD for emergency contraception on day 20 or after day 20, which in other words is after 5 days of earliest possible ovulation, if the client has additional episode or episodes of unprotected sex more than 5 days ago from this episode, right? With or without use of oral emergency contraception for that episode. Okay, so we address that in a minute. So before I particularly answer this particular case, I have taken these few points from the emergency contraception guideline of FSRH. Very important points you need to keep in mind when you're counseling any patient for emergency contraception. Basically, the EC providers should advise women that copper IUD is the most effective method of emergency contraception. So this actually is the first option you should be offering to all the women coming for emergency contraception, even if they are actually eligible for oral contraception as well. Like say they are in pre-ovulatory period and you think oral contraception can be given, still copper IUD is the first most appropriate option you should be. Only simply because it's 98 to 99% effective as compared to the oral emergency contraception, which is only 85% effective. So for every emergency contraception scenario, unless copper coil is contraindicated, please offer the women this as a first favorable method. EC providers should be aware that a copper IUD can be inserted up to 5 days after the first unprotected sex in the natural menstrual cycle, or up to 5 days after the earliest likely date of ovulation, whichever is later. So that's why it's very important that when you are taking the history for emergency contraception, so you are taking the history of the menstrual cycle and you ask the women, tell me your periods, is your cycle regular? Yes, my cycle is 28 days and I bleed for 5 days, for example. So that's fine. That is her average regular cycle. You're supposed to also ask, and what is your shortest cycle? Because she might be having, after every 3rd or 4th month, she's having a cycle of 24 days. So in that case, for somebody whose cycle can be as short as for 24 days, your copper coil, the time assessment will be according to the earliest likely date of ovulation. Means you will take the shortest cycle to calculate the earliest date of ovulation. Okay. Then EC providers should advise women that Elavon it has been demonstrated to be more effective than levonorgestrel. Okay. So if the woman wants to go for an oral emergency contraception, unless there is a contraindication for Elavon, which usually is a severe asthma, which needs glucocorticoids to be controlled. Otherwise, you can give this. You should be offering this as a first line rather than levonorgestrel. Unless the client wants to start hormonal method of contraception straight away after emergency contraception. Because with Elavon, for any hormonal method, you need to wait for 5 days to start. So that can be one. Or that person was taking hormonal contraception basically, and the method failed. For that reason, that person needs emergency contraception. And if that person has taken, hormonal-based contraceptive method in last 5 days before this unprotected sex, then obviously you can't give Elavon, because that will, compete for action. So then you will be given levonorgestrel as the first option. EC providers should advise women that the available evidence suggests that oral EC administered after ovulation is ineffective. So this is very important to tell the women. So if some women, when we have done the assessment and the calculation of number of hours, she still want to go for oral contraceptive, although we have told it's unlikely, it's not going to work, and still she chooses it, then you are supposed to say, as long as you understand this method actually is not going to work in your case, if you still want to go ahead, that's okay, we can arrange it for you. So now coming back to your that repeated query I'm getting. So the question was, can we insert the copper coil on day 20 or 21 of the menstrual cycle for a woman who has a regular menstrual cycle of 28 days cycle? Okay, so this is a flow chart. This is given actually if you go to FSRH website and then you go to emergency contraception. This is given at the end of that for you to decision making. So this is called decision making algorithm for emergency contraception. So first of all, the first question you need to ask yourself after taking all the information from the patient is currently this current episode less than 120 hours since last unprotected sexual course? So you need to see, is that within 120 hours? Yeah. Okay. So your answer is yes. Yes, the last one is. Then the next question you then need to ask, does she have any additional unprotected sexual intercourse in this cycle other than the incident she had last night or the night before? Okay. Does she have that incidence? So in our scenario, it says additional episode. So yes, she had another episode, which was 7 days ago. Okay, so the answer is yes. She had another episode. I mean, there were 7 days. Then what you need to look here now is currently, is she currently less than 5 days after earliest likely date of ovulation? Okay, so for a woman whose cycle is 28 days and either her shortest cycle is also 28 days, she says, no, this is my shortest cycle, or she says it's 26 days, whatever, then that means for somebody, let's take 28-day cycle, even the shortest cycle. She's likely to ovulate 14 days before the cycle. So her day of ovulation is about day 14, day 15, yeah? So day 14, basically. So if day 14 is her earliest likely ovulatory date, 5 days from earliest likely date of ovulation will be day 19. So that means with additional episode of any other unprotected sex, up to day 19, you can insert the copper coil. After that, you can't. Because in that case, you cannot, reliably say that she's not pregnant from the first episode. She might be a latent pregnancy. You can't exclude that with the pregnancy test on that particular day either. Okay, so if her additional episode is so her earliest possible ovulation are currently less than 5 days after earliest ovulation. If she's, so that means if she's less than day 19, then you can offer copper coil. But if it's not within the 5 days from our earliest ovulation, which in our particular scenario day 20 isn't because she has a 28-day cycle, then you can't put the copper coil, yeah? Then it's the no. So then you have, then further scenario is it more than 21 days from that episode though? So unless somebody with a period cycle of 28 days, on day 20, obviously, even if she had a unprotected first day of bleeding, but there's no risk of pregnancy anyway. So even in that case, we can't exclude that later pregnancy, yeah? So in summary, the answer to that scenario, can we insert copper coil for emergency contraception on day 20 for a woman of cycle, regular cycle of 20 days, with an additional episode of sex 7 days ago? Can we put the IUCD? No. So we need to tell her we can't. Yes, you can offer her oral AC, although we know that's unlikely to work as well. But you can still offer her because the elements, some studies have shown her might have some endometrial effect as well. And they do not have any teratogenic effect in case if she's pregnant. Okay, so this is the answer. Now, then to make it a bit more complicated, some people send me, they repeat, this is the same scenario by saying, so she did have, so she had the one unprotected sexual intercourse is last night. So that, well, good is within the 120 hours. So yes. So does she have additional protected sex in this cycle? The answer was yes. And when that was 7 days before. Okay, so that was day 13 when she had the unprotected sex, and she was given LR1 on that day. Okay, so no, they argue that she was given LR1. She had that unprotected sex on day 13, and she was given LR1. LR1 works by delaying the ovulation, so LR1 would have delayed the ovulation. Yeah, likely that it would have delayed the ovulation. So that means we are okay at day 20 basically to put the coil in because her day of ovulation is delayed. No, you're not. And the reason for that is, although she has been given LR1 on day 13, we don't know. She still might have ovulated at that time. Okay? And LR1 may not work. And even if she hasn't, what is the success rate of LR1? 85%. Right? So 15%, still there is a chance that she could be pregnant from that episode. And if she is pregnant, which you cannot exclude today by pregnancy test because it's only 7 days ago, if you put the copper coil and she was pregnant, you're actually inducing abortion, right? So if that woman is beyond the 5 days of earliest date of ovulation, then unless that episode was 21 days ago and you can do pregnancy test today and exclude the pregnancy from that episode, you cannot give copper IUCD even if she had taken the oral emergency contraception. Okay, so we're not doing we're not offering her copper IUD. We will offer her oral. Oops. So I hope that's clear and simple. So I close it here today. So please continue to send. I will try to help. Sometime I can be a little bit delayed in response, but obviously I will try to help as much as I can. And you all know we do online courses as well. Our one online course is already running. Our next 2 batches are starting on Saturday and Sunday, Saturday 18th of January and Sunday 19th of January. Sunday batch is full as well. There are a few places on our Saturday batch, which will be starting from 18th of January. So this coming Saturday. So anybody who is interested and who feel they can benefit from our coaching training for examination, you can join us for our online sessions. So I just put the contact details here. So if you want to know them to contact us, please do contact on this number. I do take a limited number of candidates. I don't take more than 10 people in my online groups as well, because I want to again individually assess each candidate in one group, and all of them perform. They're active participants. I don't believe in listener and things. So there are only few places, I think three places left on Saturday group. So whoever wants to join us, please contact us immediately before we start our sessions on this Saturday for Saturday group. Sunday group has been filled already. Thank you.